Hi, everyone. My name is Jennifer White. I'm the Director of Learning and Leadership at Futures Without Violence, and I'm very pleased to be here with you today. Thank you for participating in our webinar. This project is a joint endeavor between Futures Without Violence and the National Council of Juvenile and Family Court Judges, and we are funded through the Office on Violence Against Women. The name of our project is Enhancing Judicial Skills in Abuse in Later Life Cases. Today, we are very pleased to be sharing with you a presentation about the social and structural determinants of elder mistreatment, what courts should know. Our wonderful faculty today are retired Associate Probate Judge Tamara Curry from South Carolina, and Dr. Iggy Chang, Assistant Professor of Gerontology at Weill Cornell Medical School. Thank you so much for being here, and we're really excited to get started. So I will turn it over to Dr. Chang. And please, Dr. Chang and Judge Curry, feel free to add some additional information about your background as you get started as well. Thank you.
Sure. Thank you so much, Jennifer, for the wonderful introduction. It is my absolute pleasure to be here sharing with you all today about a research topic that I care very deeply about. So again, my name is Iggy Chen, and I'm an elder abuse researcher. I'm an assistant professor of gerontology medicine at Weill Cornell Medical College. My background is really in public health research, and given all the years that I've practiced and researched public health, one topic that really has been forming the cornerstone of my research for the past decade is really the interface of ageism, elder mistreatment, and caregiving across diverse care and cultural settings. So I am really excited to share with you our research today. Next slide, please. This is the topic of my talk today. I'd like to anchor the presentation surrounding the role of social and structural determinants of elder mistreatment. Next slide, please. Before further introduction, I wanted to disclose that there are no financial conflicts, but again, to acknowledge the funder of my continued work from National Institutes of Health. Next slide, please. As a researcher, for our research on elder mistreatment, we really wanted to first talk about a common framework for elder mistreatment. We typically use this National Research Council's definition of elder mistreatment, which refers to the intentional actions that cause harm or create this risk of harm to a vulnerable older person by a caregiver or an older person who's in a trusting relationship with the older person. And it could also refer to the failure of a caregiver to satisfy an older person's basic needs or to protect the older person from harm. And this definition will also include financial exploitation of the older person, as well as physical, emotional, and sexual abuse. Next slide, please. As we are actually right now in the middle of 2024, currently in the post-pandemic era, I actually wanted to start my presentation by traveling a little bit back through time to show you the intrinsic vulnerabilities facing older persons in relation to the risk of elder mistreatment. And it was indeed the COVID-19 pandemic really formed this perfect storm that helped to highlight several important structural vulnerabilities of older persons to elder abuse during these challenging times. So again, traveling back through time, by March 2020, WHO has officially declared COVID-19 as a global pandemic when it really took hold in the States as well as the rest of the world. And the pandemic, as we all know it, has quickly evolved with many variants. And so it's really the period of time we all now remember that the world was temporarily closed. Next slide, please. Again, the world was temporarily closed, so it really created a lot of issues, societal issues facing older persons. It is also since the beginning of this period of time that we all think elder mistreatment may have increased during this, at the time was really seemingly never ending. And this assumption that elder mistreatment has increased during the pandemic, particularly during the early months that I described, was based on a few things, as you see here. They're based on these expert warnings, including sources of WHO and UN reports, news media reports, and anecdotal stories from the community. Next slide, please. And the idea that elder mistreatment has increased is also supported by parallel studies in child mistreatment and intimate partner violence research, where researchers have found that child abuse cases and intimate partner violence cases have surged. And perhaps some of you may really very well resonate to those the days and times and the cases that you have. However, prior to at the time when our research team really delved into the issue in the context of elder mistreatment, we did not have any hard evidence, so to speak, on the potential change of occurrence of elder mistreatment. Next slide, please. And in the context of elder mistreatment specifically, there are very compelling reasons we believe that a similar surge can happen. First off, older persons, as you see here, they're often disproportionately affected in these natural as well as man-made disasters. Disasters such as the ongoing wars, older persons are really displaced from their current living environments, movement to shelters, etc. And older persons typically experience different forms of mistreatment, neglect, and exploitation during these displacements. These are the types of crises that we've seen before. However, next slide, please. The type of social disruption as we all lived through it, including COVID-19, really poses a different story. This is the crisis of being locked in. No one can leave, no one can, no other external help may be provided. People cannot go into the communities. Older persons are isolated. The pandemic had, again, created very unique challenges that we have never seen before, especially for the older persons that we care for. Next slide, please. And I also wanted to bring in some of the context that many of you have perhaps dealt with in your work, working with caregivers and in family systems. We know that caregiver-related risk factors for mistreatment have also exacerbated during this time. Thinking about formal caregivers, including home health aides, nursing aides, there are a lot of reasons that they're not able to care for older persons because of, again, structural barriers, agency guidelines that they cannot go in for fear of contracting the virus. For family caregivers, for instance, they may be more prone to becoming abusive or potentially neglectful because they themselves are also faced with challenging life and employment circumstances. All of these unintended consequences for some of the preventive public health measures can additionally bring stress to older persons as they're all in a confined space with a potential abuser and unable to reach out for help. Next slide, please. At the time, when it comes down to doing research on elder abuse, obviously we had many approaches, and traditionally a lot of research colleagues, they do APS-based research working with adult protective services, or they may be working on research based on hospital medical records. But one of the key limitations we found of these approaches is that we will only be looking at people who are identified. And elder mistreatment as it is a phenomenon that a lot of people, a lot of victims, and other perpetrators may not be identified. We did an alternative approach. Actually, we ended up doing a internet survey, and obviously it is a lot more cost effective. And then at the time, we were also be able to really fast respond to the prevalence of elder mistreatment during the pandemic, and hoping that it could shed light on some of the structural and social determinants that predispose older persons to higher risk of experiencing mistreatment and neglect during those times. Next slide, please. Again, some of the study outcomes that we looked at was based on the elder mistreatment victimization, coming from some of the well-validated measures, and you may be familiar with some of the assessments that you may or may not already be using for a lot of the court cases. For instance, has anyone close to you ever behaved in the following ways, including physical, verbal, and financial? And we also wanted to ask participants, how serious, how severe are these cases? Next slide, please. We then subsequently launched a study. This is really back again in 2020, during this time that all states have implemented the stay-at-home orders. And we had about 900 older adults took part in the internet-based survey, and the sample was socioeconomically diverse. Next slide, please. So this is what we found. As we predicted, elder mistreatment had increased during the initial months of the pandemic. If you looked at the left-hand bar compared to the pre-pandemic prevalence, about 11.6%, which was drawn from nationally representative studies. In our study during the pandemic, we found that a prevalence of 20.3%, or every 1 in 5 older persons during the pandemic had reported experience of elder mistreatment in this study sample. So that really represents a jump of 84% compared to pre-pandemic times. So looking into specifically the specific subtypes, as you see on the right side, right-hand bar, physical abuse is really what grew exponentially during the pandemic. That represent an increase of about 230%. And this is by asking the exact same statement, exact same question in our survey in the pre-pandemic study. And the question we asked is, has somebody close to you has tried to hurt or harm you during the pandemic? We really think this is quite alarming, considering that physical abuse is most likely to cause direct injury and physical health impact to older persons. We also see an increase in financial exploitation, financial abuse, and not to a dramatic level as compared to the physical abuse, but there are also financial strains and unemployment changes that really can be one of those structural issues that drive the increase of elder mistreatment during those times. Now, I wanted to also use the same data set to show you why it may be important to not only look at these individual level risk factors, to look at social and structural determinants of elder mistreatment. Next slide, please. Next slide, please. So another advantage of conducting a study like this, again, like I said, is really be able to help us look at some of the risk and resilience factors that's beyond individuals and families. By using this data set in our final regression models, apologize, this is a busy slide, but we basically control for all the existing non-risk factors of elder mistreatment. And as you can see at the individual level, we did find that older persons with greater financial strain were more likely to experience elder abuse. We actually find that as far as the preventive public health strategies are concerned, we found that the greater adherence, so people who are older persons who practice more physical distancing, were actually protective against older abuse, but those not as strong as the factor as others. But importantly is that we found older persons with stronger sense of community. In other words, at the societal level, older persons with a greater and better connected to their communities around them were actually less likely to experience mistreatment during the pandemic. Again, I wanted to use a little bit of the time to talk about this study, because I really think it sets the platform to thinking about question. And with this data, we were already starting to address this question, is that why do we wanted to study social determinants of health and elder mistreatment? Next slide, please. And let me show you this social ecological model that many of you may be already familiar with. And I'm an elder abuse researcher. So in our, wherein the researchers had is that we believe no research can be done without a theoretical model. And this may or may not be familiar to you, but we want to think about the phenomenon more theoretically, conceptually, and then start testing each of the factors that may relate to elder mistreatment and can help us think about intervention development. As what it means is really that bad things can happen at multiple levels. All of these levels can come together and drive the phenomenon of elder abuse. If you click on the next slide, or the next click, next slide, please, is that you will see the individual level and the relationship level risk factors have been well studied. For instance, the study that I just shared, financial strain may be a pronounced risk factor. We also know from all of, I think you'll agree with, some practical experiences that cognitive impairment can be a really pronounced risk driver for experiencing elder mistreatment. So we know quite a bit about that. But what is it about our society in general that still makes elder mistreatment such a prevalent and persistent problem? Next slide, please. To answer this question, this really forms the backstone of my study, is to help seek some of the structural levels that can lead to elder abuse. And if we determine it is a structural problem, then the potential for structural solutions may be at the societal or the community level. And surprisingly, following this model of elder abuse, we actually at the time had very limited evidence on the structural risk factors. So we believe that the improved understanding of the structural drivers may really help us potentially better screen and prevent and intervene on elder mistreatment across healthcare systems. Next slide, please. And there are many ways to define social determinants of health. And the way that I think about social determinants of health, as with many of my public health colleagues, are simply these non-medical factors that influence health. So these together really include the environmental conditions where individuals are, where they're born, live, learn, work, or play, or age, that ultimately affect health. And it has been estimated, next slide, please, that these factors accounted for about 30 to 55% of all health outcomes. So it is really important to address these fundamental social and structural drivers of health, especially in relation to elder mistreatment. For the second part of my presentation, I'm going to really center my talk around a key social determinant of health. It's my research program that I care a lot about. Next slide, please. In the elder abuse space, which is societal-based discrimination. Next slide, please. That really brings up the role of ageism, something as many of you may have already been doing. We all think a lot about ageism. Next slide, please. And hereby, we wanted to give it a definition. We really think about ageism and conceptualize it as a way of systematic stereotype, prejudice, or discrimination against people because of their age. Next slide, please. Just going to quickly go through some of the definitions. Some of the ageism, the way that it works, really is a large constellation of different ways that we think about negative stereotypes. So next slide, please. The first layer of ageism that you may be familiar with is really simply age discrimination, the treatment of older people in general. The second may be negative stereotypes, where these are the negative cognitive health beliefs about older people in general. And the third layer really represents the negative perceptions of aging. And this is where we think that it's such a detrimental factor that influence many of older persons' health, because we internalize these negative age beliefs since a young age. And research has done in many similar studies have demonstrated that children as young as 3 to 4 years old will already associate an older person's face with something something that's less desirable, less acceptable, if you will. Next slide, please. As I just mentioned, ageism is actually the most prevalent and culturally accepted form of bias. So this is a national representative poll of older Americans aged between 50 and 80, done by colleagues from Michigan, and they have discovered that 82% of older Americans experience ageism on a day-to-day basis. Next slide, please. However, ageism studies so far have mostly really focused on the mechanism and impact of ageism on the individual levels, without much consideration on how ageism can operate on the structural levels. To this end, our team really had the opportunity to collaborate with WHO. At the time, we conducted the first ever global review on the health consequences of ageism, which then later informed WHO's global report and the global campaign against ageism, which I had the honor of serving one of its scientific contributor for this global campaign. Next slide, please. And in this line of work, we really wanted to call out structural ageism by giving it a definition. It really refers to the explicit or implicit policies and practices or procedures of social institutions that continue to reinforce these biases toward older persons. And because of the insidious nature of structural ageism, the second level of definition we wanted to consider as structural ageism will really refer to the age-based actions or sanctions of individuals who are part of these institutions, including healthcare providers as part of the hospital, law enforcement, professionals, etc. And I'll give you some examples as we go through the slides. Next slide, please. So quickly to walk you through some of the findings that we had on structural ageism is from the systematic review that we conducted. And to our knowledge, this was the first review study that incorporated both levels, ageism operating on the individual as well as the structural level. And this was really a 3-year project where we sift through over 20,000 records from 14 different databases. And we investigated years since 1969, since the term of ageism was first coined. We did not want to set any limitations on language, publications, and study design, so we can really cast a broader net to understand ageism operating and manifesting on a global level. This together resulted in 422 studies, and in our data set, then we ended up including over 7 million participants captured in this systematic review. Next slide, please. In this line of work, again, we found that ageism, unfortunately, is a global phenomenon. Really, the impact of it manifests across country borders in all 45 countries. Next slide, please. And also, the impact of ageism is also far-reaching across time. The slide I wanted to show you here is that even though the prevalence of significant ageism health consequences have increased over time overall, combining the two lines, but research attention reflected here, as you see, actually, the number of studies in structural ageism studies actually have pivoted in about 2010, as the purple line is the individual ageism studies that continue to be on the rise, but the structural ageism studies have actually significantly decreased since 2010, as you see in the orange line. So we believe that this recent declining research interest in structural ageism would really place a limitation on the central role that our society play in promoting and reinforcing the discrimination against older persons. Let me give you some concrete examples. Next slide, please. For instance, we know that racism makes people sick. This is just a phenomenon that we all work very hard to ameliorate. Next slide, please. And as it turns out, in our systematic review, we found that ageism is worse. In prior systematic reviews of ageism, as you see on the left-hand side in the orange round bar, we use the same method to capture the associations between racism and health. So we found that 64% of racism studies have found negative effects of racism. And we used the exact same identical methodologies, and we found that over 95% of ageism studies had negative effects. Next slide, please. And from a more mechanistic perspective, we also identify several things from the study. Contrary to our intuition, because older persons actually are the demographic group that have the most access, that have the most frequent use of a healthcare system and resources. So contrary to that intuition, older persons have less access to healthcare due to their age. And this is the most well-studied mechanism by which ageism impact health. And next slide, please. So to give you some examples, older persons denied access to health care and treatment had been very well studied. For instance, we found that in about 85% of the 149 studies captured under this domain, clinicians were less likely to offer procedures and treatments to older patients than to younger patients, even if in situations where older and younger patients were equally likely to benefit. And in several studies, we also found that in large registries, older persons are less likely to receive the treatment that they desire, even if that's being voiced by their own wants and needs. Physicians and healthcare providers are less likely to grant access, and especially in some of the cases, it was these life-sustaining treatments. And we did this study prior to the pandemic, but I'm sure it rings a bell relating to some of the age-sanctioned equipments, et cetera, during the COVID-19 pandemic. There is the next structural domain that I wanted to quickly talk about. Next slide, please, is the exclusion to healthcare research. We do know a lot of the treatments as well as the pharmaceutical products that we're developing will ended up benefiting older persons, but because of the arbitrary and often very arbitrary upper age limit, older persons are not equitably participating in these trials. Next slide, please. All of these structural domain ageism then really come down to the questions: how do we really communicate this across the board? In order to drive policy priorities, we wanted to demonstrate the costs and as well as cost savings associated with ageism. Next slide, please. As it turns out, from the study that we conducted, ageism is really expensive. In our review, as well as the health economic cost benefit analysis that we conducted, ageism accounts for every $1 in $7 spent on 8 most expensive chronic conditions of the year. And this totaled to $63 billion spent in the US healthcare expenditure. And to give you just a quick reference point, this is greater than the total amount that the US spent on healthcare costs of morbid obesity for the same year. In other words, if we could effectively reduce ageism, it can also really produce cost saving, as well as the really reducing the cost on our healthcare expenditure systems. Given that ageism impacts health, access to health, as well as all the societal and financial burdens, it seems plausible that it could be the main driver to impact elder mistreatment. And our work was then examining the association and showing that it was indeed the case. Let me walk you through some of the studies that we subsequently conducted. Next slide, please. We actually wanted to first demonstrate this link at the national level by constructing a country level structural ageism index, because again, we do need better measures to understand and operationalize how structural ageism really is operating on the societal level. In one of the largest cross-national studies on violence against older persons, we developed this structural ageism index, which was based on 2 components. First, we grouped the discriminatory national policies that are relating to older persons' human rights. And these include economic, social, civil, and political rights. And the next line that we included in the index is the country level prejudicial social norms against older persons. And this part of the data was coming from the UN sponsored World Value Survey, where the survey question asked the participants whether older persons are a burden on society. And then we combine the both to construct an index. All of these are based on national level studies as well as surveys, and we're able to include 56 countries. Next slide, please. This is a report card, if you will, and the United States is somewhere in the middle in terms of the structural ageism index. Next slide, please. What we did find is that whether structural ageism may be related to violence against older persons, and this is based on the global health surveillance databases, we wanted to look at the association after controlling for some of the national level covariates, including economic, GNA per capita, etc. Next slide, please. So we were actually, as predicted, able to demonstrate this link at the national level, looking at how countries with higher levels with structural ageism was associated with greater and higher reports of violence against older persons. Then this finding would then back the question: what is the mechanism, if you will, linking a structural level determinant to individual behavior? Next slide, please. And we found one potential psychological pathway through which structural ageism relates to elder abuse may be through individuals' negative age beliefs. In other words, psychological pathway through which individuals are internalizing these negative age beliefs. We found that in two diverse cohort studies that we conducted, at the upper hand side was the one with general population of over 1,600 participants, and the second, and the lower bar, is 400 family members, caregivers. And we found that the pattern really duplicated, that structural ageism was found to trickle down through individuals' negative age beliefs that in turn increase the proclivity to be abusive toward older persons. Again, we replicated the pattern and found that it also predict family caregivers' actual neglectful and abusive behaviors toward the older family caregivers that they care for. Next slide, please. We also then wanted to show this relationship at the individual level, and many of you may also already be very familiar with implicit racism bias. And we also wanted to show that ageism as an implicit bias do exist, and as well as it's detrimental to older person's health. Again, the implicit bias is really the ones that are operating with our awareness. And next slide, please. What we ended up finding, can probably just click through. This is the measure that we have developed for implicit ageism bias, which we wanted to actually measure the most extreme form of implicit bias in ageism, which is denying humanness to older persons. So this is the IAT, or implicit association test, that we developed specifically for this context. And the hypothesis is that someone will be able to associate beliefs about older persons and animals faster in the fashion that they categorize older persons and humans. In other words, denying the humanness to older persons compared to their counterpart, which will be younger person. So again, fast forward, I just wanted to show you what we found was really concerning, because next slide, is that not only ageism had increased, exacerbated during the pandemic, but also the implicit forms have also had consequences toward family caregivers, care toward their older family members. For instance, that we saw here that the older family caregivers' more implicit dehumanization beliefs toward their family members definitely predispose them to greater risk of perpetrating elder abuse. And this, again, is controlling for some of the very well-known risk factors for elder abuse, including stress and burden, and some of the socioeconomic factors that we care about. Next slide, please. I hope that can help us give a context in why studying social determinants of health, and really the role of ageism in studying elder abuse, as well as in the real world context. Now, this brings us to the next topic of today's talk, is really what would be the way to forge forward. Some of the examples I wanted to show you in the last part of my presentation is ways in which we're developing interventions. Next slide, please. So first off, it's really hopefully a silver lining, is that we do know the detrimental impact of ageism. However, we also know that ageism can be reduced. The research study that I wanted to show you here, again, this is part of the research teams that form the WHO campaign toward combating ageism, is that researchers have found, using a recent systematic review and meta-analyses, where researchers have identified about 63 studies, and with a total sample of over 6,000 participants. So they found that ageism intervention demonstrated a strong effect on reducing ageist attitudes and knowledge. And I think the silver lining here is really thinking about the modalities of ageism interventions. What they found is that if they combine interventions with education and quality intergenerational contact, can be the intervention that can reduce the largest effects of ageism. In other words, these findings, I think, altogether can really suggest some of the relatively low-cost feasible strategies that involve increasing education and increasing quality intergenerational contact that can be the basis of some of the effective population-based interventions to reduce ageism. Next slide, please. And that also begs the question, where should we begin? Some of the really cutting edge research led by teams of researchers at Yale, by Dr. Becca Levy, they have developed this really cool ABC method, which I wanted to share with you quickly about. A really stands for raising awareness. Again, that is about changing some of the negative age beliefs that we can start by identifying and understanding some of the problematic areas. For instance, one example that I wanted to give you is potentially keep an age belief journal in work and personal and family life. Write down every portrayal of aging that we're disposed to, we are coming across, and question these negative portrayals. I think the key here is to recognize the diversity of aging, that older persons, just like every other group, is really diverse. B is blaming ageism, not aging. And I think this probably resonates with many of you. For instance, one example I love to give is a lot of times I forget keys when I just open my front door. I forget my key on the front door. And a lot of times that you joke about, oh, it must be that I'm getting old, I'm getting memory problems, etc. But that is really ageism, not aging, right? A lot of times you may just be tired. Again, it's really be consciously aware that the good place to start recognizing ageism is that this is what makes aging difficult. The belief about I see someone saying the senior moment language, that is absolutely something that's been operating really without our conscious. And again, if you go to pick out happy birthday cards, and these are the senior moments, I think all of us can be more consciously aware, and recognizing that is what makes aging the villain. Ageism is the cause of the problem, not aging. C, again, challenge age beliefs. The more we challenge these negative age beliefs, the less firm that their grasp will be on our behaviors, on our actions. Last but not least, next slide, please. I also wanted to give you another example in which we can work with the social determinants of health in a more practical way. This is the example I wanted to give you. Next slide. It's actually by working with providers. Next slide, please. Next slide, please. Can we advance to the next slide? Thank you. Again, it's because as a researcher, many of us work very closely, intimately within the healthcare system. So another lever to think about is really helping the providers to be more culturally aware of age bias, as well as of a lot of hosts of different biases that may be really functioning without our awareness. Next slide, please. Provider linguistic as well as cultural sensitivity may be a key example or a key beginning point that we can work with. Next slide, please. Again, this is a concrete example I wanted to perhaps leave you with today with my presentation. We have been working with many nursing home providers on the West Coast to come up with this Care Matters. Essentially, this is a toolkit developed for our certified nursing assistants, because they are the ones who are really bearing most of the responsibilities as well as hard work helping the most vulnerable older persons in our institutionalized settings. But many of them are also consciously aware of their biases, including ageism. So other words, we wanted to develop a very practical toolkit that they can use within their day-to-day work. And CARE stands for curiosity, awareness, rooting out bias, as well as empathy. And the rooting out bias practice that we essentially developed is really surrounding challenging their negative age beliefs. Because again, CNAs, just like the rest of our healthcare providers, a lot of times that the only patients that are residents or older persons that they work with on a day-to-day basis represent the most vulnerable older persons in our societies. However, there are also other older persons representing this wide diversity of aging. Being able to tease that apart and challenge some of these negative age beliefs, we believe, will be an important way to equip our providers as well as practitioners to be able to reduce the impact of age biases that are operating with our awareness. Next slide, please. So again, this is we're still piloting this program, but we feel very confident that it may be hopefully really making an impact to our residents in institutionalized settings. Many of the CNAs have said that this really helped to better provide cross-cultural care and communication. So this again is another example to help address some of the cultural sensitivity in the realms of age bias as well as racial bias, which is another line of my ongoing work, while CNAs can be better equipped to reduce biases that may also another downstream effect will be reducing potential mistreatment, neglect, and exploitation. Next slide, please. I think that will really sum up my talk today. Next slide. Again, these are some of the key references. Next slide. And I really look forward to our Q&A. Next slide, please. I wanted to acknowledge, again, research. This is a team effort, my mentors, collaborators, and many of the research participants who really graciously share their wisdom and time with us. Next slide. Next slide, please. This is my contact information. I really look forward to hearing from you and looking forward to our Q&A. Next slide, please. I wanted to really making the segue to our next speaker, Judge Curry, who will be speaking with us about many things that some of the ageism research that we've done to a judicial audience, that what does it mean for older persons that we serve in general and for our court practice in particular. Thank you again, and I'll hand off to you, Judge Curry.
Thank you very much. Good afternoon. My name is Tamara Curry, and I am a retired probate judge, having served for 24 years, hearing a number of cases with guardianship and conservatorships and other areas related to elder abuse. And I can tell you, as a judge and now an attorney practicing with the General Counsel's Office for the South Carolina Department of Mental Health and working with adult protective services, and again, additional cases with our elders in the court, that it's a huge problem. And Iggy is completely correct in stating that after COVID, the number of cases that the court heard in regards to issues with caregivers and in the home. And one of the things that we've seen is when we look at the dynamics of the home, we have a number of elders who are now themselves guardians for family members, such as incapacitated adults, and also even grandchildren and great-grandchildren. And so we have seen even elder abuse cases in family court related to juveniles who live in the home. And when we look at some of the signs that you see in court, even if you see these signs, oftentimes our elders don't want to report it. They still desire to stay in living in unsafe conditions. Sometimes reports will come in regards to unexplained injuries, bruises, cuts, broken bones. And when questioned as to what has occurred, was there abuse, the answer will be either I've fallen or I tripped, but never to say that the abuse has occurred by even a caregiver, who oftentimes they also view as family members and they also love. And one of the main things is most elderly people don't want to be moved from their home, even if they don't have the ability to care for their daily needs. And so there may be reports that there are poor personal hygiene when they go to doctors, or neighbors who may have come by to visit and realize that there is a change, that the person is malnourished, that they're not being fed. And family members may be living in that home, and even the neighbors don't want to sometimes report that this is going on. Oftentimes also that elderly person may be fearful or anxious of additional abuse, or do they have a right to speak up? And unexplained transactions or loss of money, financial exploitation is huge. You oftentimes have a caregiver, a family member, or someone who's close to that person who's been a surrogate family member who is misusing the personal property of the elder adult, and those monies are not benefiting the elderly person. There may be coercion and providing gifts, transferring properties. I had a case where the elderly person who was so lonely had been exploited by her realtor. And she had even purchased a home for the realtor. And when the family members found this out, because there was no one who was there on a daily basis, it's a friend, somebody who is bringing that elderly person food, taking time out with them. Financial exploitation is definitely real. Next slide. What can we do if you're on the bench and measures to counteract and to impact ageism? As Iggy has indicated, unlike domestic violence and care for minors, elder abuse, the surveys that are being done are now being looked at, but the amount of attention that is given to ensure that the elderly person has access to advocacy, that they feel that they have the ability to speak up about the mistreatment without retribution, and that they know that they have a right to say no, is often difficult to make sure that they have access to advocacy, because oftentimes the person who is committing the abuse is the person who is caring for that elderly person. And that elderly person often knows that if that person is not there to assist, then who can be there to help them? We need to ensure that they know that their voice will be heard, that there's protection there, and we need to educate the family members and our elderly individuals that they have civil rights that have to be respected. And it may indicate if they don't have that capacity, or if they need assistance, that a legal guardian or conservator may need to be appointed. And it depends on what jurisdiction you're in, whether or not the guardian is considered a conservator, but usually there is someone appointed to assist with the day-to-day needs, placement, making medical decisions, placement decisions for that elderly person, and also a conservator to ensure that their finances are going to be considered. And again, whenever you look at capacity issues, you always look at what is the least restrictive. Are there some basic needs that the person can still maintain, but may need assistance on a daily basis to make these decisions? And we're going to talk a little bit later on in the slide. What do you do when you do have a guardian or a conservator appointed, and that procedure has gone awry and the abuse is coming from that appointed fiduciary? An option, depending on what court you are, may be to appoint an attorney, GAL, to investigate and to see what's in the best interest of that elderly person. Because no matter what, you want to respect the wishes and the autonomy of that elderly person. And there's a fine line between making sure that you can respect their wishes, but also doing what's in the best interest for that elderly person, especially if it is clear that there is abuse going on and that elderly person wants to continue to live like they're living, to live with that person, and still wants that involvement of a person who basically is not operating in the best interest of that elderly person. We want to also be able to refer them to services. And in order to refer them into services, we have to know in our individual communities, what are the resources that are out there? From a court standpoint, it's our duty to ensure that we have this information available. So when people come to court, that we're able to provide them with resources if there's financial exploitation, if placement is an issue. Staff, along with us as judges, need to ensure that we are aware as to what those services are. Doing court is very important as you are trying to respect the wishes and the autonomy of the person who's before you, that you use trauma-informed language and a demeanor that speaks to the elderly person. It's not condescending, but in a way that they understand that you are trying to look at what is in their best interest, that your language is safe, supportive, and that you don't trigger additional trauma. When you have someone who's coming in and they already have trauma and you just talk in such a demeanor that this is what's going to occur, we're going to take your assets, there's going to be this third party who's coming in, you don't know who this individual is, they're now going to be paying your bills, they're now going to be making placement decisions. You can traumatize that elderly person even more. And so you have to understand what trauma-informed language is, and that you're speaking in a demeanor that they understand that they do have rights, even though there may be court intervention. You have to recognize the common trauma reactions, including the fact that as a result of what you're doing, that person may be self-medicating, there may be substance abuse issues, or even challenges trying to check or to track even the assets that the person has or information that you may need in order to follow their plan. And you're going to need to know how to address acute financial and housing crises. If you have a case and the person is before you, they may not have the correct medical insurance in order to place them in crisis housing. So what do you do? What do you do when a person needs to be moved out of an environment tonight? What are your resources? What are your what is available in terms of housing crises, and what is even out there if that person needs crisis housing. Next slide. Off the bench, you have to consider how accessible your court is in involving older adults and seeking recommendations for improvement. And I found over the last definitely 5 years, that even though our courts are being more accessible with how we involve older adults, sometimes you can have a case and it may be referred to APS, and APS is not our problem. We think the problem is the probate court. They need to go to probate court, and probate courts, no one's filed a petition here. And so we keep playing tag with our elderly. There are very few elder courts that deal throughout the country that deal with our elderly. But what we need to do is to make sure that our courts are accessible, that we are working on recommendations for improvement. And often this is done through our state legislators. It's done with working with other agencies, with partnering, but we must make our courts accessible, and not only to make them accessible, but to also make the information related to what's available, what resources are there if you need emergency housing, what resources are there to assist if the person needs to just apply for Medicaid and Medicare, and they haven't done that. What resources are available in order to have an ex parte emergency order for a guardianship or a conservatorship? And do we have these outreach materials available? One of the things that our court did is we met quarterly with a number of various agencies, some that dealt with dementia and Alzheimer's and placements and hospitals and emergency rooms and places that we could refer family members to. And so all of this outreach material should be available. And if there are no organizations serving, then we need to work on expanding this information. I find that if you're a judge and you're the one who calls the meeting, the people will come. And we have to be able to serve our older adults and to reach out. And I'm going to name a number of resources that may be available in your various locations. Next slide. You need to find out the options for treatment in your area, as I've indicated. According to Emerge, about 9 in 10 of the Batter Intervention Program participants are there for elder abuse. You, as I've indicated, need to provide court community cross-training. So not only do you need to have the stakeholders at the table and to partner with them, but you could provide the training and have those who have the expertise in the various areas to be present and to offer the training yourself, and that could come through your court. You can be involved in coordinated responses or task force. Some states have task force. The example that is given, a model state, is the New York Elder Justice Committee. They have produced bench cards. They provide training, engage multiple arms of the community, mobilize COVID responses. In our state, through our state elder committee, we provide training throughout the entire state for individuals to talk about what these resources are, to talk about financial exploitation, how to identify it, how to identify elder abuse, and to explain what's available statewide. But it's very important because if your state is like my state, we have 46 various counties, but the majority of those counties are rural. And so the resources in the various counties will differ depending on where you're located. And so what may work in Charleston, South Carolina, may not work 70 miles away in a place called Walterboro, which is a rural area. The other things that you will need to do, we spoke about guardianships and conservatorships, is that you will oftentimes have to oversee the actions of guardians and conservators. Next slide. As I've indicated, oftentimes you may have to appoint a legal guardian or conservator to manage the assets of those persons. However, sometimes those guardians have failed in their fiduciary duties and the funds are not used for the benefit of the ward. You may have cases where the person has transferred personal property, real property that belongs to the ward in their name. And it's very important when you have guardianships and conservatorships that you have safeguards that are in place. If you find that you have a guardianship or a conservatorship, and when you are looking at annual accountings, you must have annual accountings. And the only way to ensure that you are able to investigate that the funds are used for the benefit of the ward is to have annual accountings. You know that your guardianship is going bad if the accountings are late. I personally do not suggest that they have ATM cards, but they have ATM cards and you look and large amount of funds are being withdrawn. What you would need to do is you can freeze those assets or place the monies in a restricted account. The court may use these actions to limit a family member or guardian's access to the money. In some of my guardianships, the guardian would have access to the money, but it would only be up to $500 and or some amount that you believe based on the assets that the person has. So you may restrict those funds, and the guardian or conservator would need court approval to expend monies except for normal. If you believe that the guardian is misusing the funds or there's an allegation of malfeasance, the court can appoint a guardian ad litem. Some courts have investigators who can investigate the adult. If you don't have an investigator and there may be alleged physical abuse, you can call your law enforcement agency and have a wellness check to be done. And after the wellness check, if it's determined that there is something that's going awry, then you can go further. The court can also audit an individual's assets through a court order or accounting. We have yearly accountings that are provided, and failure to do so may be grounds for removal. But I definitely believe that it's very important to do that. Next slide. One of the other things that the court can do is when the person is appointed is to require that they are bonded. And failure to be bonded may be grounds as to whether or not the person can or cannot serve as guardian. And background checks are also very helpful. From a court standpoint, if you find that there is lost funds, the court may require that the elderly person be restored as a result of the lost asset. And in many ways, again, to ensure that the person is going to be restored is to have the bond. So I am a proponent of bonds. Again, some courts are not, but at least the person can be made whole again if a bond is in place. You can enforce statutory rights to communication and visitation. In a lot of these cases, you'll find that there is isolation. A family member or several family members have isolated others from visiting that elderly person and using undue influence. However, your court orders can be almost like a family court order where there is a visitation schedule that is set up so that ward is able to communicate with members of her or his church, other family members, other activities that they may be involved in, and all of that can be placed in an order. Next slide. You can also appoint a co-guardian or limit the powers of the guardian. Again, in most statutes, especially the trend among the country is for the least restrictive, and for that guardian or conservator or the alleged incapacitated person to be provided as much of their civil rights as they can maintain. And by limiting the guardianship or the conservatorship, that may be an option. And having a co-guardian appointed may also be an option, but know that normally with co-guardians, that person would not have the ability or one of those individuals to make those decisions without the consent of the other co-guardian. And so if you're going to appoint co-guardians, know that you should not appoint people who are adverse to each other or are unable to work unless it's a third-party guardian. And again, you can always remove the guardian or terminate the guardianship. Termination of the guardianship is probably your last resort unless the person has put into place a durable power of attorney or power of attorneys that allow someone to take care of their finances and their placement if there has already been a hearing indicating that the person is in need of assistance. Because if the person is in need of assistance, then what you may have to do is to terminate the person who's appointed as the guardian who has been abusing their fiduciary duty and appointing another guardian. And so you have to know that once that person has been deemed incapacitated, unless there's a hearing to restore them and they have been restored, then you just can't just terminate the guardian without having a successor guardian appointed. Next slide. Additional priorities. We want to always make sure that there's access to justice. We've learned from COVID-19 that we can have remote proceedings, provide detailed procedural information available online and by phone. One thing that COVID taught us was that if we were not ready to deal with what do we do when we're in a crisis, that COVID made us ready. And I believe there's still a number of courts that are providing remote hearings, virtual hearings, and we had to provide the information so that the public was informed. And so we need to continue to update and to provide access to justice so that people can be provided this information remotely. Safety planning. What professionals think a survivor needs versus what the survivor wants. You have to trust their narrative and desires while offering all options. And as I indicated, with guardianships and conservatorships, and when you're dealing with people who have trauma, we need to make sure that they know that we're listening to them. But even though we're listening to them, we need to look at what are the options? How do we make them safe? How do we keep them safe? But we need to still take into consideration what their desires are. And sometimes there are times when what they want, we may not be able to order or to give. But you have to look at each case on a case-by-case basis and to see where there may be some give, where there may be some take. So with an elderly person who has a child who they may still want to visit, it may be that they will have supervised visitation. Because if you stop the visitation, they may then decide that they don't have the desire to live, or they may stop eating. And so you have to take all of these things into consideration when you're looking at a safety plan. You want to make sure that you prevent homelessness. Abuse is a cause of housing insecurity, especially when the elderly person has moved in to the home with a child or family members. And oftentimes the survivor will have to remove themselves from the situation because they can't get the abusive person out. So it may be that You may have to move them out for a period of time in order to make sure that a guardian ad litem or an attorney has filed an action to have that person, the abusive person, removed out of the home who is refusing to move. We need better housing for our survivors. The way we do that again is through the partnering, looking at some of our homelessness initiatives and making sure that those initiatives are not only addressing those who are on the street, but also our seniors, along with our veterans, along with children and families, that there's a place at the table for our elderly also. Pro bono eviction services for survivors who may need to evict abusive family members, to look at alternative protection orders that can be done through sometimes pro bono services. And again, I think one of the most important things that Professor Chang has indicated is that the more we advocate, the more information that we provide, the more access to services, the more informed the community will be, and it will make it easier for us to provide additional services for our elderly. Next slide. Additional priorities. Do our jails and prisons alienate? What are our alternatives? Restorative justice, broken relationship, trust between an abuser, a survivor, and the community. We have to make them accountable to the person, not accountable to the system, and a depersonalized crime. We have to look at community-based programs or programs for the survivor and the abuser to work together. And this is where our education comes into play. Next slide. Some of the promising practices that we've seen, some of our probate courts have local attorneys who volunteer times to be in our courthouses to answer questions and assist regarding probate matters. We have some of our large firms who are willing to provide free services to review guardianship filings or to even file some of these filings. We can recruit local attorneys who are willing to answer questions about probate matters. We can use community social workers to assist elderly litigants in compiling information for use in court and to help develop care plans. One of the other things that's not listed on here, throughout the country, some courts have started what they call monitoring programs in their guardianships and conservatorships. And with these monitoring programs, they have a system where the cases are reviewed, the elderly persons are visited so that it's almost like sending out an investigator. Some schools, like our county, used law students who went 2 by 2. We randomly pulled the files. They were visited so it's almost like a wellness check to ensure that the person has been going to the doctor, that their basic needs are being met, that they're living in a safe environment. And in the cases where the guardians refused to allow us to come, those cases were brought before the court. And so the issue is to put your eye on that particular ward, and not only by paperwork, so that we can ensure that they are clean, that they're being cared for, that there's no abuse. And when we see red flags, we pull those files. They're notified that there's going to be a home visit. The person is brought in so that we can review their reports, their accountings. So there are practices that are starting to take place, and we just have to ensure, no matter where we live, that some of these practices that we're implementing in our courts. And I believe my time is up and that we are going to open the chat for questions that have been asked through the chat box. And I thank you very much. And I will provide my contact information for you.
Thank you so much, Judge Curry, and Dr. Chang for your presentation. We have a couple of questions and comments, so I will share them out to you and we can address them. In the meantime, if folks have additional questions or comments, you can feel free to either put it in the chat box or in the question and answer. The first question came in through the chat earlier, and it was to Iggy about situations when an older couple both accuse each other of abuse amid potential dementia of one partner. So she submitted the question when you were discussing your study. So I'm not sure if that question means how do you track for that, or if that in terms of your research, or if that has to do with what are the solutions to that. I don't know if the person who asked that wants to clarify in the chat. Or if you have initial thoughts, Iggy, I don't know.
Sure. Yeah. So I saw that question coming through the chat, and I'll speak from a perspective where I think perhaps many of our audiences here deal with on a day-to-day basis, which is really perhaps that's especially true in dealing with cases where individuals have cognitive impairment. And I'll probably drop this in the chat as well, is that it's important to be able to determine someone's capability of thinking about decisional abilities. And I think this is what Judge Curry actually shed light on as well, is that someone's decision-making abilities may be very different from cognitive impairment. Someone who's cognitively impaired may not be able to make long-term decisions such as finances, but someone with cognitive impairment may be able to make a decision right on the spot in terms of deciding the what to eat, deciding when to go out, etc. So I think medically there are important decision tools that will help us tease those things apart. And I think in one of those cases where, again, going back to what Judge Curry mentioned, is that it's again believing the fact that our clients, our patients, have the ability to make the best decision to their interest, but that should be under the circumstances where all the options are offered, all the options are put on the table. So I don't know if that specifically addressed that question, but again, we struggle quite a bit in terms of working with clients and patients with cognitive ability and as well as cognitive impairment. The tool, I'll try to drop in the chat, maybe something that may be helpful in our audiences here.
Great. And there was also a question when you were in the portion of your presentation, Dr. Chang, discussing the identifying factors associated with elder abuse, asking if there is any type of survey form associated with identifying those risk factors. And the person said, I'm a church leader. In addition to being an attorney working with involuntary commitment defense, wills, and powers of attorney. So they were asking if there was any kind of tool to be able to identify those factors associated with the factors you were looking at.
Yeah, so thank you for that question. So typically in the research setting, we do a lot of surveys. And I think this question, to my understanding, perhaps have two layers. One is that a survey is typically the tool that we use getting at these risk and resilience factor. Another thing I wanted to throw in there is that we talk a lot about deficiencies. We talk a lot about financial dependency. We talk a lot about social isolation, etc. But I encourage all of us to think about, on the flip side, what are some of this larger protective factors? So social connectedness may be one. A lot of times we actually think about spirituality. So I guess this will address the question from our church church leader audience here is that spirituality and being able to have the platform to connect to the rest of the religious community can be a very important form and has been backed by research to be another form and tenant of social support that may prevent abuse from the victim's perspectives as well as from potential perpetrators. So that may be one in terms of what research can demonstrate from a survey perspective. And I think the second layer to that question, even if we do a lot of really interesting and cool studies and we go to these academic conferences, but I think there's still this disconnect, which I'm hoping that by doing this kind of presentation is really to help us connect to bringing research to practice, thinking about some of the practical implications that ageism can transform to our everyday life and the impact it can produce within the courtroom, often on the bench, etc. Again, I think we would love to do more community-facing outreach type of research activities so that we can really break down these research findings, if you will, to everyday toolkit that we can all use to practice reducing ageism and in the long term, reducing elder mistreatment.
And in addition, with respect to the toolkit, I think you just attached that, right, Dr. Chang? Is that
Yes, I just
okay.
sent that tool to our chat box. It's called IDA. This is really the decision ability assessment tool that us at Weill Cornell, led by Dr. Mark Lex, who's one of my mentors, as well as researchers at Penn. And this is actually in collaboration with folks on the ground, with APS workers, to use these decision-making tools to understand patients as well as older persons' ability to make decisions. Because again, as you'll see on that page, there's really this fine distinction between cognitive impairment and decision-making ability. So the least thing we want is for anyone in the power of making decisions to say, hey, this person has dementia. So that's it. There's no more thing that we can be done, or there's no more conversation that we need to engage the patient. One example that I can give you, for instance, in healthcare encounters, we have seen many cases where older patient shows up with cognitive impairment, Alzheimer's, and the provider will very naturally start engaging the care partner without really addressing the patient in the room with dementia. That again is something that you can obviously call a very explicit form of ageism, discrimination against patients with dementia. I think having these more important tools and practical tools can help us better circumvent these barriers, and also really engaging older persons with chronic diseases, illnesses, including Alzheimer's, to be part of the decision-making process.
And there is a comment in the Q&A that I will read out to you. It states, this is important information. However, as a person from a historically marginalized population, it is extremely complicated when a family member deals with racism, ageism, mental health, systemic oppression, etc., in addition to the lack of resources you're suggesting or other feasible alternatives. So it was just a comment that they were putting in there, not a specific question. But if either or both of you have any response, feel free to weigh in on the comments.
I think the only response that I'd like to make is to just make sure that you are aware of what help is out there. So you, in most states, you may have a long-term care ombudsman program that may provide you with additional resources and help. Sometimes some of them have funds that may allow family members a weekend respite, and it's funded where the person may be taken from the home for a weekend. I had a member at my church who could never attend church on Sunday because there were not funds to bring someone into their home. However, periodically she was able to access those funds. There are also area agencies on aging and disability resource centers in most states who also provide you with some of that respite information. A lot of the legal aid societies, which is based on income, are there also to possibly assist and are now taking cases for guardianship and conservatorships. Whereas years ago, they were only doing domestic violence in cases with children. And so those agencies are also available and may be able to help no matter where you're located in your state, especially when you have individuals who have issues related to racism, those sorts of things. I got a call yesterday trying to assist someone with a family member who suffers with mental illness, over 50, living in the woods. How do we provide services for that particular person? He has pretty much all of the factors that we've spoken about today: race, age, homelessness, cognitive issues, mental illness, some and RP, and that is correct. They're also a huge resource. And one of the things that I like about RP is they have separate um books and pamphlets related to the appointment of guardianships, conservatorships, trust, and they're very helpful in most of those. You can utilize and download online if you would just put AAR.
There was also a question related to the work that you have done, Dr. Chen. And the question is, has any of this work incorporated intersectionality of age and race bias? I know that you've worked extensively in that, so if you wanted to respond.
Yes, absolutely. And so to give you an example, the structural ageism index work that we've done that I showed you earlier, looking at national level severity of the structural ageism measure. The one way we actually validate that tool is by looking at how does that interact with countries that have higher level of racial and ethnic biases. And that's really the intersectionality that we found, is that countries that reported higher levels of structural ageism happen to be the countries that also reported higher level of racial ethnic biases as well as gender-based biases. That is at the country level, but I think we're really trying to boil it down to community as well as individuals. So one example that I can give you, the study that we're currently doing look at resident to resident aggression in nursing homes. And what we have found is a lot of residents in our nursing home and institutionalized settings do experience aggression from other residents on a day-to-day basis. We also find that these residents, a lot of them happen to be from minoritized backgrounds. So it's really that compounding effect that we're really trying to tease out. It's not just the experience that predisposed them to higher risk of aggression from other residents, but also the lack of healthcare access also make the consequences even more severe from these minoritized residents who are older and more vulnerable. But again, I think it's also important to think about some of the protective factors, because a lot of minoritized older patients in the health in the hospital that we see, nursing home, they also have very important traits of resilience that we know. Social support is one, connected to religious communities is another. So really thinking about the pros and cons of different communities will be important to address the problems and potential solutions that would come from these intersectional type of analyses.
There is a question that states, what are the challenges impacting older adults, especially low income and technologically challenged older adults, with courts moving to paperless? I don't know if you have any thoughts about that, if you've been exposed to.
Correct. It makes it difficult. And so that's why most courts, even though they are going virtual, they provide virtual options and also e-filing, that you must still maintain paper filings, in-person courts. And so the courts are taking all of that into consideration, because there are people who don't even have connectivity. If you're in a rural area, sometimes it's very difficult to even have Wi-Fi that is working on a consistent basis. And that's why I'm happy that we have some legislation where hopefully in the next 2 years, there will be connectivity available for all persons. And even though we have all of these interventions and things available. We still have to still do things the old way and make it available for those who are not comfortable with technology and not comfortable with virtual court, but to make sure that our courts are accessible for everyone, no matter which way they prefer to actually operate. The one thing that I do want to say, though, in regards to having the remote court with those who do have connectivity, especially even with some of the services, lack of health services, is that the services are now being brought to the person if they're able to use technology so that they're still able to get the services, especially those who don't have adequate transportation, or if they lived in a rural area and it's a 20 or 30-mile trip, to be able to see your doctor through telemed, or to be able to provide court if there are family members or neighbors who may be able to assist them. Is that on the one hand, it makes these services available to them when they're not available. But if they're still needing to do things through paper, it's still available.
Yeah, I just wanted to add too, I know in our Judicial Institute, we have one of our faculty members who is a geriatric psychologist who does capacity assessments. And one of the things that they have done is move to doing those assessments in the homes, visiting older adults in the home, and also trying to figure out ways to do some of those assessments virtually where it's possible, but have articulated a preference for actually going into people's homes and doing that because of the important information you get from being in someone's
Right.
living space.
And then we also want to make sure when we talk about accessibility that if there are language barriers, that is being addressed prior to you having a hearing, or you getting there and realize the person needs assistance because they don't speak the language.
Mm.
It may be Mandarin, it may be Korean, it may not only be Spanish, but that we are providing that information. And also, if the person has hearing issues, that we're providing whatever that need is so that they can participate in the process.
And there was a comment actually just a moment ago in the chat from Diane about the fact that deaf advocacy organizations are an important resource for older deaf survivors in her community and generally. And I think the same would be true for organizations that are serving individuals with disabilities across the board, would be an important resource to consider. And I think there's one more comment. And then Lisa is noting that in some states, there are mobile mental health crisis units that can help people who are temporarily or chronically unhoused. Assertive community treatment is a self-contained transdisciplinary team staffed with a team leader, psychiatrists, nurses, social workers, therapists, and specialists, such as in the area of co-occurring substance abuse treatment, employment, and educational services. And she put a link into the chat if folks are interested in taking a look at that. Any other questions from folks, either they want to put in chat or in the Q&A? There are none in the Q&A currently. Dr. Ching or Judge Curry, any concluding or additional comments you wanted to make?
I think that the one comment that I would just like to make is that in order to see a difference in our communities, it's going to take the individuals who've attended the webinar to assist their communities if they are lacking these resources, and that it's going to behoove us to put together these resources, because if they haven't been done previously, someone has to take the step and to lead in order to do, because as we see our aging population and individuals living longer, we will still see an increase in the numbers and individuals that Professor Chang's surveys have included.
Yeah, I agree very much. And I really think the takeaway message here is that the resources may be available, but it's really the access and the understanding of where and whom to seek resources. And again, that is a very important structural determinant of our health, let alone in the ageism or elder abuse space. Going back to the structural ageism piece that I talked a lot about is that we are also part of the group or the communities who may be the champions in making that impact along with the rest of our communities. Again, it's really, I'm very pleased to be participating in a panel as such, and I hope there will be more opportunity to speak to the research to practice implications of all of our important work. Thank you again.
Thank you so much. I just wanted to take a quick moment to express my gratitude to Judge Curry and Dr. Chen for their generosity of their time and their wisdom today. We really appreciate it, and it's always such a pleasure to work with you. So I thank you very much. I also want to thank our partners at NCJFCJ for um, supporting the work and helping us today on the webinar, as well as our funder, the Office on Violence Against Women. If anybody has any additional questions or needs, please do reach out to me. My email is on the last slide. There we go. And you can reach out to me or to my partner, Jenny Towncon at NCJFCJ. Happy to respond and help you with anything that you might need. And thank you all again for being here with us today and talking about this important issue. So, hope everyone has a wonderful rest of their day.
Thank you so much.